And now it gives me great pleasure to introduce FHNN's President, Evan Smith.
Thank you, Louise. I'd like to welcome the members and volunteers from FHNN, Little Falls, and other villages, as well as those who are not yet part of a village. For those of you unfamiliar with the village movement, we're neighbors helping neighbors to age in place and lead fulfilling lives. Special thanks to Louise for organizing this program in collaboration with Margaret from Little Falls. Now, let me introduce Dr. Bob Slager, who in turn will introduce the speaker. Bob was a family physician who practiced in Calvert County, Maryland for 30 years and in Maine for 12 years. Throughout his career, he dealt with both hospice and palliative care patients. So please welcome Dr. Bob Slager.
Hello, everybody. I'm so happy to be here and to be able to introduce our speaker. As Evan said, I'm a family physician who practiced for many years and did take care of many patients who required both hospice and palliative care. Yet, even among experienced medical professionals, there still is some confusion as to the appropriate roles and the differences between palliative and hospice care. And I'm sure that Rory will go into that in the very near future. So we're really fortunate to have such a knowledgeable and experienced medical professional to talk to us today on both hospice and palliative care. Rory Farrand is a board-certified adult nurse practitioner. She also has a Master's of Science degree in nursing that's focused on geriatrics and adult health. She also holds advanced practice certification in palliative care, a Bachelor of Arts in Psychology, a Master of Science in Behavioral Neuroscience, and a Master of Arts degree in art therapy. So you can tell she's a very multi-talented person. Rory recently became a full-time consultant with Confidis Consulting group. Prior to that, just recently, she was serving as the Vice President of the Palliative and Advanced Care for the National Hospice and Palliative Care Organization. She's had over 20 years experience in palliative care, geriatric, primary and acute care, geriatric psychiatry, assisted living management, clinical research, innovative program development, and many other things. So as you might suspect, she's held many other leadership positions, and I'll forego that so that she has more time to speak to us today. So without further introduction, let's hear from you, Rory, and if you could please share your knowledge with us.
Thank you, Bob, and thank you, Louise and Evan. I'm really excited to have the opportunity to speak with you all today. I'm going to get my screen ready to share, and I'm gonna move this other thing out of the way. Please just give me the thumbs up if you are seeing my screen. Okay, good, I'm glad. All right, so as Bob and Evan and Louise mentioned, my name is Rory Farrand, and I am, like I said, very excited to speak to you all today about palliative care and hospice. Bob's not wrong. As a physician, even physicians and other clinicians really struggle with understanding how palliative care and hospice are the same, how they're different, and when it's the right time to have either of those types of care introduced into the care of folks. So what my goal is today is to help you understand the difference between palliative care and hospice services. There are some very key differences between those two approaches to care. But there's also a lot of common misconceptions, and I'd be curious as we go along if any of you have any questions or concerns. As Louise had mentioned, please put those in the chat. But there's a lot of, I think, misinformation out there related to what palliative care is and can do, the same thing as what hospice is and can do. There are some critical differences between who might be eligible for which type of care. We are going to talk about that. People often wonder, how is this paid for? We'll talk a little bit about that. And then towards the end, I will provide some practical guidance for all of you that may help you or a loved one make some informed healthcare decisions, especially if you are concerned about, thinking about, or someone has offered to you hospice or palliative care. I'm going to make sure I leave plenty of time to answer any of your questions, so please put those in the chat. And as I mentioned, my goal today is to provide you knowledge and information, because whether it is you or someone you love, there's probably a good chance that at some point palliative or hospice services might be something that is of interest. So why is this an important topic to talk about? I don't think it will come as a surprise to anyone that the demographics of our society is changing. As folks age, many folks have not just one, but actually multiple chronic conditions. And many of those conditions may actually become serious, or in some cases terminal. As you probably are aware, people are living longer with various types of illnesses, which is a great thing. It's one of the wonderful benefits of some of the advances in medicine that we've had. But what that also means is that sometimes the side effects of those very treatments that are aimed at trying to help folks with different types of illnesses, those themselves may actually cause some very serious symptoms. And so if you've ever known someone who's been dealing with cancer or renal disease, the treatments themselves may actually cause some pretty serious side effects. But our healthcare system in and of itself is changing. There has been increased focus on patient-centered care and an increased focus on quality of life. I'm sure Bob can speak to this, that physicians themselves, healthcare institutions as well, are actually being, if you will, judged and graded by our payers, by Medicare and others, as to how well they put the patient and the patient's family at the center of care. As well as, are we actually achieving various types of quality outcomes, which I think is really exciting. And for all of you, what that means is that you really can be in the driver's seat as it relates to your care. I think a lot of times folks take, no offense, Bob, take what the doctor says as sort of gospel, as the thing to do, but you are always encouraged and allowed to say, hey, I have questions. I'm not sure that that treatment is right for me. Let's talk about it. So that's part of what we talk about when we mention patient-centered care. We have a very, very significant need for better pain and symptom management. Pain is one of the most challenging symptoms to actually address. And folks like me, palliative care clinicians, we are trained in terms of how to manage these very difficult symptoms. Pain is one of them. Dyspnea or shortness of breath, nausea, vomiting, really any symptom that may come from an illness or the treatment for that illness is something that we're trained to deal with. Of course, healthcare costs are increasing, and as people live longer with these various complex and sometimes serious illnesses, people may be juggling as many as 5 different physicians or 5 different types of services that are aimed at helping you, but actually get really confusing. So we need to figure out a better way to make sure all of that care is coordinated, that everybody knows what's going on, and that really there is one person driving that care. And in an ideal universe, that should be your primary care physician. Caregivers are the most underserved, undersung heroes of our community. So whether you're a spouse and you're caring for a loved one, or you have a sibling who is ill, our caregivers in this country are not paid. And we know that there is a significant toll on caregivers in terms of their own health. So that's, again, another reason why this conversation today is really important, because palliative care and hospice can help support family caregivers. And as it relates to palliative care, you often may hear palliative care as sort of a bridge between comfort care or curative interventions for an illness. So we can talk a little bit about what that actually means as I move along. So to sort of, rather than continue to ramble and not bury the lead here, people really always want to know, what is palliative care? So the best way I can describe it is that palliative care is an extra layer of support. The idea is that while you are living with an illness, you can have a really good quality of life. So let's use something like cancer treatment as an example. We know that the types of treatments that are commonly prescribed for cancer can make you feel sick to your stomach, can make you feel really fatigued and tired, sometimes may actually cause pain. So if you have a palliative care physician or nurse practitioner or a team that works with you while you're receiving care for that serious illness, that we can help address those really burdensome symptoms. And the reason that is important is that the outcomes of care are better, of course, if you're able to actually receive the treatments that have been prescribed for you. So rather than maybe missing a chemotherapy treatment because you feel too unwell to go to that, if you have palliative care involved, we can help make sure that you feel the best you can with this illness, allowing you to get to the treatments that you need to get to so that you can actually have the best possible outcomes available. I can't imagine anyone on this call is excited about going to the hospital or especially spending any time overnight in the hospital. So our goal for folks who provide care at home, care in the community, we really want to make sure that you spend as much time at home with the people that you want to spend time with and not have to waste that time in the hospital where you're not allowed to spend time with your family. So that is one of the other things that palliative care can do, is make sure that you are able to spend the time where you want to be. I mentioned that the coordination of care is something that is increasingly challenging. So a lot of times we palliative care clinicians end up kind of taking on that quarterback role where we figure out what sort of the throughput of all of your treatments are, and making sure that your clinicians that are taking care of you all are on the same page and that everybody is talking to each other. So we can help sort of wade through some of the difficult communication challenges. We can help clarify confusing or sometimes misleading or sometimes even contradictory instructions from your physicians. So that's one of the things that we can do, is help those physicians talk to each other. Now, here's one thing that I think is really important, especially as it relates to palliative care. Palliative care can be provided at any stage of an illness. So a lot of times people will say, and we'll talk about this when we get to misconceptions, people think that palliative care is just for folks at end of life, and that is patently false. Anytime you have been diagnosed with a serious illness, you can actually ask, or I like to say demand, to have a palliative care consult, because studies have actually shown that the earlier palliative care is introduced into as alongside treatment for an illness, you actually do a lot better. So palliative care is not just for end of life. Palliative care can really be introduced at any point. And again, the palliative care team is often made up of many different types of individuals. Bob's a physician, I'm a nurse practitioner, but you also might find that there are RNs, registered nurses, on the team. There are a lot of social workers on the team. There's also chaplains on the team. So as you think about all of the things that make us human, that make us sort of unique and different, we try to make sure that there is a team member who can address all of those kinds of concerns. So, oops, that didn't advance, did it? Okay, there we go. A lot of times people will say to me, well, you know what? I've never heard of palliative care. What's going on? Well, there has been, over the last 20 years, very significant growth in palliative care programs. Now, the most common place that people are going to be introduced to palliative care is going to be in the hospital. That's partly because that's where a lot of programs started, but more and more palliative care is being found in community settings. So that could be, like I said, care inside your actual home or in an office-based setting. Sometimes specialists like oncology or nephrology may actually have an embedded palliative care team within their practice. There are some outpatient practices, but more and more we are seeing palliative care, like I said, found outside of hospitals. Palliative care historically was also kind of associated with specialty types of medicine. So again, oncology is really, I keep bringing that one up because oncologists were kind of the first group of physicians that really understood the benefit of having palliative care. But now we're seeing nephrologists, so the kidney doctors, we're seeing heart doctors, cardiologists, pulmonologists. All of the different specialties are starting to recognize how much benefit palliative care can provide to their patients. So more and more we are seeing palliative care embedded in these specialty care settings. What is really interesting to me is that from as primary care physicians are also starting to recognize that their patients need palliative care as well. So the great news is that palliative care can be found just about anywhere at any time. I mentioned that patients live longer and do better when palliative care is introduced early. There's actually studies that show that patients who receive palliative care at the same time that they are receiving, for example, chemotherapy for cancer, compared to patients who are receiving the exact same type of chemotherapy but no palliative care, the ones that receive the palliative care intervention alongside the curative treatment actually live longer. So I think that's a really interesting statistic. So if you are somebody who maybe someone has introduced palliative care to, please don't think that the physician is telling you that it means you're dying or that you're at end of life. Yes, palliative care can be provided, of course, at end of life, but it does not necessarily mean that that's where you are in terms of your illness. If anything, it means that this is an opportunity to try to help you live as well as possible with that illness. And then, of course, as our population is changing and people are living longer and with additional chronic conditions and serious illness, we are seeing an increase in demand, which is really exciting for someone like me who has spent her career in this space. I'm really excited to have the opportunity to see nursing students and medical students starting to ask about the opportunity to learn about palliative care, which I think is really, really exciting. So, as I mentioned, palliative care is not the same as hospice care. And the reason this is important is because that's going to be one of those misconceptions I hope to remedy for you. So, I'm going to start on the right side of the screen here. Hospice care is a specific type of palliative care that does require the individual to have a prognosis of 6 months or less. It is actually a benefit that is provided through your Medicare Part A, and it is comfort focused, meaning that you will not be receiving any additional curative or disease modifying interventions for that terminal illness if you choose to elect palliative care. I do want to emphasize that hospice really is the most enriched Medicare benefit that you can possibly imagine. It is, and I'm going to talk about its details in a slide or two, but it really is a benefit you've paid into the entire your working life or your spouse's working life. And so I like to say that, if you don't use it, you lose it. So it's really important to know that this is something that is a benefit as somebody who is receiving Medicare. In contrast to having to have that prognosis as a criteria for being eligible for hospice care, palliative care is based on need. So as I mentioned, it can be offered at any part in someone's illness. You don't have to have that 6 month or less prognosis. It is a specialty service and it's billed through Medicare Part B. And what that means is Medicare Part B is the part of your Medicare that pays for your physicians and things like that. Whereas Part A generally covers your hospital stays. The other part of your Medicare benefit, the Part B benefit, is how palliative care is primarily paid for. And I mentioned, and I really want to underscore this, palliative care can be provided while you were receiving treatment for any of your other illnesses. And as I mentioned, it's an extra layer of support that does not take away any care, but in fact, enhances the care that you're already receiving. So to sort of graphically represent this for you, I have this table here. The similarities between palliative care and hospice really have to do with the goal of both approaches to care, being that we are helping to help you have the best possible quality of life and to manage symptoms. We have an eligibility slide that's going to come up, but I always say that there's really only 2 things that you need in order to be eligible for palliative care. And that is you have symptoms that are bothersome to you. So if you have, for example, very problematic shortness of breath, or you have pain or fatigue or any type of symptom that causes you stress, that's one of the reasons that you could ask for a palliative care consult. You also may be yourself a caregiver, or you are aware of a caregiver in your life that is really feeling overwhelmed or stressed or burdened by helping care for somebody who has illness. So that caregiver stress and strain can also be alleviated by having palliative care support. So on the slide here, we talk about sort of the timing. Palliative care really can be introduced, as I said, as soon as somebody has been diagnosed with an illness that's considered to be serious or potentially at some point terminal. Hospice, of course, has to have that 6-month or fewer prognosis, and 2 physicians have to agree that that prognosis is 6 months or less. As I mentioned, palliative care can be provided alongside of those curative interventions, whereas if someone is thinking about hospice, I do need to emphasize that any type of intervention that may be considered curative or disease modifying, such as chemo, radiation, dialysis, those kinds of things, those do have to be given up. So eligibility, as I said, any serious illness, there is no sort of time-based prognosis for palliative care. Like I said, there's two things, symptom burden and or caregiver stress and strain. And of course, the eligibility for hospice is at a minimum this 6-month prognosis. There is a number of things that also help us as clinicians understand if somebody might be hospice eligible. And then there's also specific criteria related to someone's particular illness. So eligibility, for example, somebody who has an Alzheimer's type dementia looks very different than somebody who has cancer or who has heart disease. So there's some sort of general criteria for hospice eligibility, but then there's very specific disease criteria. As I mentioned, Medicare Part A, which is again the hospital benefit, is also the benefit, the part of Medicare that covers hospice. But any type of insurance you have, whether that is your Medicare Part B, Medicaid, your commercial plans, the Blue Crosses, the Aetna, the Humana, all of those different kinds of things, that is the group that would pay for your palliative care. Of course, because it's a physician approach to care, it's Medicare Part B, there are deductibles, of course, and copays. Whereas on the hospice side, you as the recipient of hospice, everything that you need related to your being cared for during this terminal part of your life is covered. So what that means is that all of the visits by any of the clinicians are paid for. Medications related that you might need during while you're on hospice, those are paid for. Durable medical equipment, whether that is hospital beds or oxygen, all of those different kinds of things, those are also covered under the hospice benefit. So it really is, like I said, a very robust, very enriched benefit that basically takes care of everything. Most people receive hospice care in their home. Sometimes there are hospice facilities that are standalone, or sometimes they are leased beds from a nursing facility. But for the most part, people receive hospice wherever they call home. And you can receive palliative care just about anywhere, in the hospital, in an office, in a clinic, in a nursing facility, assisted living facility, or home. So palliative care kind of can be received anywhere. So here's I like to sort of share this visual. Oh, I didn't share it yet. I like to share a visual that kind of helps, I think, explain when hospice and palliative care can be introduced. So if you take a look at the the bottom part of the screen where it says time course of an illness, as somebody is first diagnosed with an illness, it makes sense that people want to try to cure that, to get better. But as that illness progresses over time, those types of interventions for managing those illnesses start to become less and less effective, or maybe the treatments are actually causing more problems than they are helping. So over time, you can start to sort of diminish the amount of reliance on curative or disease modifying therapies, and at the same time, increase the amount of reliance on palliative care. When somebody reaches that 6-month prognosis, that's when hospice can come on board. And not everybody starts hospice at that 6-month mark. People tend to elect it at various different times. And then hospice is involved providing palliative care all the way through somebody's end of life. After death, hospice also provides bereavement care for those, your loved ones, for 13 months. That allows you to work with social workers and chaplains and all of the other folks involved in the interdisciplinary team for over a year, 13 months after the person who was receiving hospice's death. And I think that's a really robust benefit and something that you don't see in any other approach to care. So a lot of times people are, where did that go? That went 2 different directions. people ask, how do I know when palliative care is needed, or how do I know to the same extent when hospice is needed? So as you think about yourself, or you think about folks that you are in contact with or that you care for, if you are having increased hospitalizations, so often we use as a benchmark 3 or more hospitalizations in a year, that tends to indicate that your illness is progressing and becoming more advanced because you are having more need to be in the hospital. Those uncontrolled symptoms, whether that is pain or shortness of breath, nausea, any symptom really that is causing you any kind of stress or strain or is burdensome, that's another indicator that palliative care might be a good introduction to your care plan. Sometimes we see folks lose weight or have functional decline despite everything that they're doing their best. They're eating a lot. They're trying to maintain their functional status, but they continue to have decline. That's another indication that an illness is advancing and might be good to bring palliative care on. Dealing with one illness is challenging, but dealing with multiple illnesses, especially as they're serious, is challenging. And of course, as folks start to need help with their activities of daily living, whether that is dressing or other types of grooming, transfers, toileting, those types of things, as people need additional assistance, that's often, again, a time that palliative care can be a support. But in and of itself, the physical things that come with illness, there's often, a lot of emotional things that we all experience when we're diagnosed or someone we love is diagnosed with a serious illness. It's very distressing. It's also, a lot of times people ask questions, that their physicians, no offense to Dr. Schlager, can't answer, like, why me? Why did this happen to me? What's going on? So there's some sort of sometimes spiritual questions or existential questions. So palliative care teams, as well as hospice teams, as I mentioned, include social support, social workers, but also chaplains and other types of spiritual leaders that can help you sort of answer the types of questions that may be bogging your mind down at night, making it difficult for you to sleep. I can't imagine anyone on this call has a 100% perfectly wonderful family that agrees with everything, each other all the time. I spend a lot of my time helping families navigate difficult dynamics. Sometimes, we have family members, one person in the family wants the person with illness to do things this way, and somebody else wants them to do a very opposite way. And sometimes families really don't even like talking to each other or have a lot of trouble talking to each other. So palliative care clinicians, we are trained in helping navigate really complex family dynamics, helping folks make decisions that align with their personal goals and wishes and values, and walking people through those advanced care planning conversations. So again, if you have a family that's challenging, and I'll raise my hand as one of the first families that I'll admit to, my sister and I do not see eye to eye, and we don't definitely see eye to eye in terms of how to support my dad in terms of his care. So we actually are working with a palliative care team where he lives in Florida to make sure that he's getting the type of care that he needs, but also helping us make sure that we're informed in what's going on at the same time. So again, my mouse is very sensitive today. So the biggest thing to remember as to when to know when hospice is needed has to do with that terminal illness having a prognosis of 6 months or less. As I mentioned, this is not just one person's opinion. In order to be eligible for hospice, 2 physicians need to certify that the illness is in fact terminal, and that a person would not, that if the illness were to follow its natural course, they would not be surprised if in 6 months the person died from that illness. The patient, though, you as the patient or you as a support person for somebody who has a serious illness, they need to agree that there is no more interest or intention to pursue any kind of curative care. So again, that means that there is no further interest in pursuing additional, for example, chemotherapy or radiation or dialysis or things like that that are considered sort of disease modifying or curative interventions. And sometimes that actually is something that's taken out of our own hands. Sometimes the treatments that are being offered are actually more burdensome and cause more harm than actual good. So sometimes we get to a point in an illness where the decision around giving up treatments is taken out of our own hands. And just because I keep mentioning this 6 month prognosis does not mean that if you happen to be on hospice and you're on for 6 months and then 6 months and a day comes, you're not kicked off hospice. I want to make sure that is made very clear. We have hospice has very very regulated protocols. And one of those is a recertification process. And all that means is that, again, somebody makes that determination that, yes, you are still in that terminal phase of illness. And yes, based on the criteria as it stands today, it's still not going to be surprised if you were to die in 6 months. That recertification process happens about every 2 months after that initial certification, just to ensure that everybody's on the same page as it relates to prognosis. So again, I just want to underscore that you're not kicked out because you didn't, I hate to say it like this, but this is how I've seen it written in the press, because somebody didn't die fast enough. That always bothers me. That's absolutely not allowed to occur. So as I mentioned, again, I really believe in hospice. I think it's a really wonderful benefit, in part because I mentioned it's a very regulated benefit, and Medicare requires hospices to provide all of these services that you see on the screen. You have to have an interdisciplinary team of professionals. So you have a physician that's involved, you have nurses, you have social workers, you have a chaplain. There's also a very robust volunteer requirement. Any medical equipment that you need to be supported living at home with your illness once you're on hospice is provided. So again, hospital bed, bedside commode, things like that, oxygen, all of those are covered, as are the medications. So I think this is something that is really important. Medications are incredibly expensive, even if you have a Part D plan, and worse if you don't. But medications are often a very significant burden to folks. So that's something that is covered by the Medicare hospice benefit. There are 4 different types of care that must be provided by a hospice, and depending on what your needs are, any one of those that you can see at the bottom of the screen are what might be offered to you. So the most common care is what's called routine home care, and that just means that you are able to receive care in your home based on what your needs are. But sometimes symptoms and may actually be so significant that it's really impossible to manage in the home itself. So sometimes folks can go into an inpatient unit. That could be a standalone hospice facility. It could actually be in a nursing home. Sometimes it's even in the hospital. And what that means is that the symptoms are so serious that it needs this very intensive intervention in order to get those types of symptoms under control. Similar to inpatient care, sometimes continuous care, meaning you have 24/7 a nurse managing your symptoms, that can actually be provided in your home. But obviously, if it can't be provided in the home, folks may go to one of those other facilities I mentioned to get those symptoms under control. And then again, thinking about back to caregivers, caregivers manage a lot when caring for somebody that they love with a serious illness, and sometimes need a break. And there is nothing wrong with needing a break. Hospice is able to offer respite. So what they do is that gives an opportunity for that care provider to, whether it's something as exciting as going on a trip, or just even having a little bit of time to breathe. Hospice has opportunities to sort of take that care off of that caregiver and provide support for a period of time. And then, as I mentioned, this is on the top right, that bereavement support. It doesn't, there's no roadmap for how we grieve, and however anyone grieves is the right way to grieve, and nobody can tell us differently. So sometimes it's really helpful to have somebody else to talk to. So hospices have dedicated bereavement support for, as I mentioned, 13 months after a person's death. So here is something that I always think is a kind of interesting aspect of conversations, this idea of how we can bust some of these myths that people most may believe about both hospice and palliative care. I blame any medical-based drama that has been on TV in the last 20 or 25 years for this particular one, which is, palliative care means giving up. ER, Grey's Anatomy, all of these different types of medical shows, you always hear somebody say, there's nothing more we can do for you. Let me refer you to palliative care. I want to bust that myth more than any other one. In fact, palliative care and hospice is a very aggressive form of care. It's just focused differently. So it does not mean giving up. It means we are going to focus on ensuring that you live the best way you can with your illness for as long as we can help you live that way. So of course, palliative care can be provided, as I mentioned, with that curative intervention, but even hospice, hospice is for folks in the terminal aspect of an illness, but that does not mean that people are just going to forget that you exist. I really like to describe both of those approaches to care as really aggressive. And actually, we're specially trained to manage all of the challenging things that people experience in serious and terminal illnesses. I've heard a lot of times people still believe that cancer is the only diagnosis for which you can get either palliative care or hospice. That one is actually born from a kernel of truth, but it is no longer true. When the hospice benefit was first trialed in 1978 and then written into law in 1982, it really was intended for folks who had cancer. But of course, through the 80s, different types of other illnesses were added to the eligibility criteria. So while it started out as a benefit for folks who had cancer, because think about that, late 70s, early 80s, treatments for cancer were really limited and very problematic. Nowadays, there's all kinds of immunotherapies and targeted therapies and all these different kinds of things. So folks live a lot longer with cancer than they did 40 some years ago. And again, palliative care is beneficial for any serious illness at any point in that illness trajectory. So a lot of times people think that, palliative care or hospice comes in and we kind of take over and we tell everybody what to do. If anything, that's what we do is we go out of our way to ensure that the patient or the family who's at the center of care, that your care choices, your preferences are one, identified, and two, upheld. So we often go to bat with our other medical and nursing colleagues to make sure that what patients want are understood. So the patient preferences and the voluntary nature of both types of services is paramount. So if you choose to no longer want palliative care, you can disenroll from a palliative care program. If you choose that you don't want hospice anymore, you can come off the hospice roll and go back to receiving treatment. There is no penalty or anything for making, changing your mind. We want to ensure that what you need is being met and that you are receiving the type of care the way you want to receive it. So sometimes people think that palliative is not covered by Medicare. As I mentioned, hospice as a type of palliative care, as well as palliative that is not provided by hospice, both of those are covered by traditional Medicare. And of course, palliative care is covered by other types of payers, our commercial plans, Medicaid, and things like that. That's not to say that hospice isn't covered by commercial or Medicaid. It's just that most folks, disenroll from those other types of payers in order to receive Medicare hospice benefit. It's not a requirement, but that's something that a lot of people do. This is the other thing I used to hear all the time is that, my mom went on hospice or my aunt went on hospice, and as soon as she went on hospice, they died. Or they gave somebody morphine and then they died. Neither hospice nor palliative care hastens death, nor does it mean that death is imminent. If anything, as I hope I helped articulate a little bit, both approaches to care can improve quality of life and may, in some cases, especially in terms of palliative care, can actually extend survival. So again, I want to make sure I underscore the voluntary nature of both of these services. Both to receive palliative care or to receive hospice, patients have to be informed about what all of that means, and we do have to get your consent. I want to emphasize this because there's been some very unscrupulous actors in certain parts of the country that were focused on by a ProPublica news article, and then that was picked up a couple of years ago in some of the national press, where patients were being enrolled in hospice without their permission. That is absolutely against the law and should not be happening. And those were limited to a series of bad actors in a couple of states. But Medicare is very aware of some of those sort of fraudulent behaviors, and they have put a number of checks and balances into place in order to prevent those types of things from happening. So let me underscore that as a patient or as a loved one of a patient, you always have the right to decline or discontinue either service. You also have the right to choose providers, again, on the palliative care side within your payer network. And then you have the right to choose your hospice. There is not just one provider of hospice. I like to say that you think about it as dating. You kind of need to interview a couple of different organizations because sometimes you might vibe better, you might connect better with certain staff at one organization as compared to another. So you have the right to choose folks who come into your home or provide your care in an office, depending on either your payer or whoever you feel most comfortable with. The transitions between various approaches to care, so that the movement from palliative care to hospice often happens when either curative options are exhausted or somebody no longer wants to pursue those. And then on the flip side, if you have enrolled in hospice and you decide that, you know what, this is not really working for me right now, and you want to leave and go back to your curative treatment, you can absolutely do that. And then maybe a month or two later, you think, you know what, I would like to go back to hospice. There is no penalty to come back onto hospice if that is your choice. So we're getting a little closer to the end of our presentation. So I want to provide you some practical questions to ask. So perhaps you're somebody or someone in your family has a serious illness and you're thinking, you know what, I would like to receive palliative care. I'm going to tell you a secret, and Bob will probably validate this. A lot of physicians, as I mentioned, really are not clear on what palliative is or what hospice is, so they don't often recommend it. And they may be in that ER Grey's Anatomy camp of there's nothing more we can do, so I'm going to refer you to palliative. So they may be surprised if you say, hey, I would like to receive a palliative care consult. So this is the part of the presentation, and I emphasize this again at the end, that if you have those burdensome symptoms, or you are, as a caregiver, feel stress and strain related to caring for that person in your life that has that serious illness, you can ask for a palliative consult and stand your ground. Get the consult. Most people I have ever worked with have often said to me when we started caring for them, I wish I knew about this sooner. Why didn't anybody tell me about this? My mom died when I was in my early 20s, and I wish that I had known about palliative care. I wish I'd known about hospice. And actually, her illness is the reason that I went into this field in the first place, because my whole perspective was I didn't want any other family to ever experience the really kind of horrible experience that my mother went through at the end of life. So I am a strong believer that you don't just ask for it, demand palliative care. But if you are somebody who is not receiving your insurance through Medicare, Medicare is the cleanest and easiest to get either palliative or hospice through, but maybe you have a Blue Cross or an Aetna or a Humana. You can often ask, how is palliative care covered under my plan? It is a specialty practice. So sometimes you have to be in network and sometimes you have to get a referral. Again, Medicare, you don't have to do any of those kinds of things, but it would be important so that you're not blindsided to know who provides palliative care in your network, what would the cost sharing responsibility be, whether that's, a copay, where do you fall in the deductible sort of window? Are there any visit or service limitations? So for example, would you have to, if you're, again, this is not Medicare, would you have to receive your palliative care in an office or in an outpatient setting versus a home-based care? So it is important for those other types of insurers to understand what might be considered visit or service limitations, and of course, pre-authorizations. Everybody's favorite thing. Hopefully you don't need a pre-authorization for palliative care, because that's just a horrible nightmare to have to deal with. And again, Medicare does not require any of those types of things. But these are some questions that you can ask either your primary care physician, your specialist, or your insurance provider if this is something that sounds like you would be interested in. Oh my goodness, my mouse today is like having, is being all sensitive. Okay, so practical guidance for decision making. I think it's always important to talk to the person who knows you best, and hopefully that is your primary care physician. If you've had a long-standing relationship with that individual, they probably know you and know what matters to you. But sometimes, as you know, you're dealing with a serious illness, you may be spending more time with a specialty provider. So if you're thinking about palliative care, definitely introduce that idea to those providers and make sure that they understand what you're thinking. If a referral is required, be certain to ask for it. Research who provides palliative care in your community. It could be, and this should not startle anybody, but sometimes palliative care in the community is provided by a hospice organization. That does not mean you've enrolled in hospice if you're looking at the palliative care side, but just be aware that sometimes both hospice, home health organizations, they may provide palliative care as one of their services. I've found that patients are sometimes surprised if they call the number and they answer such and such hospice. I just want to make sure that that is something that would be on your radar. Always come prepared with a bunch of questions. You know, what can you do for me? How can you benefit? What kinds of who's on your care team? Will I have the opportunity to talk to a chaplain or a social worker? Make sure that there are questions that that palliative care program is able to answer for you. And of course, you can even ask those folks about insurance coverage. We often are very well versed in the various payers that work with our agencies. So we probably know some of those answers for you and are happy to address those. Of course, if you or your loved one is considering hospice, you most of the time we do have to ask that prognosis is discussed openly with us as patients or with our family members. I'm not going to throw all physicians under the bus. I'm going to assume that Bob is the best physician ever to walk through Maine or any other part of the country. But the reality is some physicians and other members of the healthcare team really don't want to talk about end of life care. It's a challenging conversation. There's a lot of feelings, a lot of emotions. It's a difficult topic. But if you have questions or you're concerned about your prognosis, you might have to ask. We know that 80% of patients want their physicians to talk to them about their prognosis, but they're waiting for the doc to bring it up. The doc is going to do everything they can to not bring it up. So sometimes you might have to ask, and sometimes you might need to ensure that they are comfortable talking to your family members as well. I think, like anything else, explore options before there's an emergency. I really think that if we aren't prepared, then sometimes decisions are made for us that may not be the decisions we would want to make for ourselves. So if you are early in the stage of an illness that might become serious, just get to know who might be providing hospice in your community, who you might want to reach out to if that is something that you get to the point that you might need hospice level support. Be sure to research those options. And like I said, it's like dating. These are people who are going to come into your home or where you are living, and they're going to be working with you at a very sort of fragile and sort of delicate time of your life. You want to feel comfortable with them. So do feel comfortable interviewing and asking people questions and making sure you choose an agency that that feels comfortable for you. And of course, understand what to expect. I think sometimes hospice is explained in a way that makes people think that they're going to get 24/7 nurse aid coverage, or that an RN is going to come every single day. The reality is whatever it is that you need is going to be the type of services that are delivered for you. And that's going to change as your illness progresses. So you may receive less visits. You have to be seen at least every 2 weeks, but you may receive less visits or different specialists in the beginning than you might receive as your illness continues to progress. And also think about what you might need to receive care in your home. Do you need durable medical equipment like a hospital bed? Do you have oxygen? Do you need it? Those kinds of things. How could you possibly prepare your home that would make it easy for hospice to come in? And then this is really kind of my, I think my second to last slide. This is for everyone. Please think about your preferences for your care, and not just end of life care, but your care in general. So what are you comfortable receiving in terms of care approaches, and not just what, but where? If you don't want to go to the hospital, then you need to tell somebody you don't want to go to the hospital. Everyone over the age of 18 should have an advance directive. That's going to sound surprising to people. And I don't mean necessarily a POLST or a MOLST form, like the one that the hot pink form that you have to sign that says you don't want resuscitation. But if you do not want to be hospitalized, or you would not want to be intubated, or you would not want to receive artificial nutrition or hydration, all of those different kinds of things, those can be included in your advance directives. But the one thing that I think is interesting that people don't think about is other types of things. I'll give you an example with my own dad. He has made it very clear that he does not want any type of bathing or dressing support from myself or my sister. This is a dignity thing for my dad, and he has made it very clear that he does not want his children to have to see him in that state. So that's something that we know that if and when he comes to the point that he's no longer able to care for himself, we are going to have to bring in a support for him. And that's fine, we're prepared for that. But I really appreciated that he was able to share with us that that's something that he would be embarrassed for us to do, and he did not want us to see him like that. If you already have a serious illness or you're caring for someone who has a serious illness, please make sure you discuss those preferences that we just talked about with somebody and make sure that they know what your preferences are. You might need somebody to help you with financial decisions, and tell everyone your wishes and your preferences, not just once, but multiple times, because sometimes they may change as well. And that's everyone should include your healthcare providers, not just your PCP, not just your adult daughter, but all of the folks that are involved in your care, including any of your family or extended family that may be involved. I like to think this is a gift that we give, having these conversations. That means that somebody in a crisis does not have to make decisions for me that they may not feel comfortable with. They know that they will be making decisions that I would want. And then keep those conversations open, because things change as we move through various stages of our illness. And so here's what I'm going to have you walk away with, because I know we're getting close to time, and I promised that we would have time for questions. Please make sure that you understand that palliative care really is an added layer of support, and that you can receive it at any time, and no one's going to offer it to you. Make sure you ask or demand it. And then, of course, hospice is specialty care for folks who are at the end of life. It is a very enriched benefit. It's intended to improve quality of life and support caregivers, and again, provides bereavement after your loved one has died. So I'm going to move ahead to our opportunity to do questions. I do see that there's a bunch of stuff in the chat, Louise. So
Yes. So I'm going to stop the recording and